describing, I mean, I think the shame is just absolutely key with her. That makes her hold back. I mean, as we said, guilt makes people want to confess, shame makes them want to hide, and so she keeps hiding what she's really feeling underneath.
Well, one of the things you said to me before when we've talked about her is don't chase someone with a hysterical character.
Right.
So
if someone's tendency is to run away, you're not going to help by chasing after them.
Welcome to In Contact with the ACO. I'm Dr. Chris Burrett. During the pandemic, we will continue to host webinars about various clinical topics, and we hope you'll attend. When safe to do so, we will resume our case presentations at the ACO campus near Princeton, New Jersey. You can connect with us and learn more at adifferentkindofpsychiatry.com or orgonomists.org. In this episode, you'll hear a mentoring session between two medical orgonomists, but before we begin, I'd like to ask you a favor. Please share an episode with a friend or family member, and if you use Apple products, leave a review and a 5-star rating in the app. One of the best ways you can support the ACO's efforts in reaching out to a larger audience is by sharing a podcast episode. Leaving a review gives prospective listeners a chance to see that the podcast is worth trying out and a way for the ACO to connect to more of the public. As always, we're open to hearing how we can improve, so if there's any suggestions or comments, please don't hesitate to email us at aco@orgonomists.org.
to go over with today. One is she's the hysteric who's very has great difficulty speaking up. She's been seeing me twice a week.
So again, I want to keep urging you to talk about her as this person with an hysterical character. She is an hysteric.
Yes. Okay. I knew that.
She's more than her neurosis.
Yeah. So much more. But I'm very worried about her. I just saw her this morning, and she looks more depressed to me. She is really having a hard time speaking up in the session. And yet she's communicating a great deal. So she sits back, and then through the session she'll sit forward, and it almost looks like she wants to spring up and run out of the room. She puts her fist over her mouth, and I'll say to her, what is that? And she'll drop it down. But she purses her lips, it's down on her lips. She shakes her head no all the time, and I say, go ahead, shake your head no. What is that? And what she was able to tell me today in words was she has an incredible amount of shame connected to some childhood memories. And that is really in her way, and she's had it for years. And she's really struggling, and she looks more depressed to me than I've seen her in a while. She has a history of cutting, a history of suicidal thinking, no attempts. She's not drinking, not doing drugs. But the more we get into this slowly, she's suffering terribly. And she said to me today, I am so hard on myself. I can't forgive myself. I can't forget what happened. And she functions. She goes to work every day. And she has friends.
I'm sorry I didn't mention it in my readings, the story about the woman with the chronic pain that I read about. When I was going over that with Morris, he said, is this related to what goes on with people who are cutters? And I thought, wow, how insightful. And I had not looked at it that way. Cutting is essentially a self-induced conversion disorder, that instead of tolerating the emotional pain, they will convert it to a physical sensation. People have talked about, it makes the person feel more real, but as long as your perceptions can be transformed into physical sensations rather than emotional pain.
And that's what looks like it's going on with her.
Yeah,
she
well,
gets these sensations
Yeah.
and pains and throbbing in her body. And
it's the emotions are just so intolerable for her that she's converting them to sensations. But I never thought about cutting as essentially mechanically inducing that conversion.
but I'm worried about her.
Oh.
And
What does give her relief?
I keep asking her that. She does report relief after some sessions,
Okay.
not all of them.
Can she identify anything about that?
I asked her that today, and she wasn't able to tell. What looks like to me is when she's being very hard on herself, that she does not get relief.
Uh-huh.
If she's putting less pressure on herself, she's able to kind of discharge more. But
Right.
it's like the shame immobilizes her. And today, my observation of her, given her character, was she sat, and at one point she became just frozen like a statue. She froze.
Yeah.
And I said to her, "You look like a statue right now. Are you aware of that?" And she said, "I do that a lot." Uh-huh. So she must have been aware of it, but it's the first time I acknowledged it, and we said it together in the session. And then when she does move, some of her body motions are, it looks like she's, like her face looks like she's in intense pain. Mm-hmm. Her arm will move in a way that is like she's trying to swat something away, or she's trying to move and run towards the door or out the office. She has trouble making eye contact with me. And then sometimes I'll say to her, just take a breath, and then maybe she'll make eye contact with me, but often not. She's terrified. So, and she's so stuck. I mean, the orality, we talked about it before, the orality, she's stuck in that, but the shame is a part of what stops her from being able to express herself. She cannot even say it. She says, "I think it all the time, but I can't say it." So I'm worried about her. So we decided I'm going to see her probably twice next week, just to increase support. She has my number; she can call me. But
well, when you say you're worried, what are you worried about?
I guess the cutting, suicidal thinking.
So how long has it been since she cut?
No, it's a while. A couple of years that I. It's not. That's not a current problem,
right.
But that is in her history.
And you said suicidal thoughts. I mean, she's having suicidal thoughts?
No, not now, but that's been something she's reported in the past.
Remind me, how long have you seen her?
Since June.
Okay.
Last June.
So has she
7 months.
reported suicidal thoughts since you've been seeing her?
Once.
Okay.
Once came up.
Okay.
And what she does when she gets them is she just distracts herself. She'll go do something, call a friend, go out to friends for for dinner. And she has a lot of wonderful friends, which is thankfully.
But what you're describing, I mean, I think the shame is just absolutely key with her. Yeah. That makes her hold back. I mean, as we said, guilt makes people want to confess. Shame makes them want to hide, and so she keeps hiding what she's really feeling underneath.
Well, one of the things you said to me before when we've talked about her is don't chase someone with a hysterical character.
Right.
So
if someone's tendency is to run away, you're not going to help by chasing after them.
Right. So I was very silent in the session.
Yeah.
Way more than I usually. And I was aware of that. Like she needed the silence. She needed to just sit with whatever it was she was feeling. But the suffering.
But that's the key. Is does that bring her relief? And so that's what you have to find out. Is she needs to be able to sit with things. So that means you need to be silent, but you also need to evaluate. Right now, can she tolerate that, or does that just make her shut down more?
Right. Well, I found myself moving towards wanting to reassure her. It's like that, acknowledging how hard it is for her. and that she's been through this before, because she's had other therapists, she's touched on some of this before, and that she is healthy in her, deep down in her core, she has a very healthy core, and that she could get through this. Look at how far she has come in her life. So, I offered that to her, and she nodded a little bit, but it's still, the shame's just so loud, she can't hear that kind of whisper, almost.
Yeah.
So she asked to come in sooner than next Friday. So she's going to come in on Tuesday.
But the bottom line is as you said, she needs to be able to overcome the shame and speak. She'll get relief by just being able to speak up. But there's all that stuff in the way. So.
Well, she started the session by talking about her mom.
Okay.
So there might be a lot there related to her mom that we've never really talked about.
Okay. So stay with where she's already able to express herself.
And my heart breaks for her.
But I wasn't sure when you're saying your impulse is to reassure. Are you thinking that's a problem, or that would be a good thing to do, or?
I felt like she needed it.
Yeah. Okay.
To just leave her dangling without that kind of support at the end. It was right at the end as we were kind of closing the session.
Okay. So
just felt like the right thing to do.
Yeah. So follow. You have good instincts, so follow your instincts about that. Yeah. The other thing is if we're correct about her character diagnosis, she's not fragile. She may be very sensitive. She may be suffering. And so she needs your encouragement, and that includes not treating her as if she's incapable of handling all this.
No, I think she's quite capable of it. She just doesn't know that or believe it.
That's right. Yeah. So any implication that she's too fragile to handle it, will undermine her own desire to deal with it. So, which is very different than, as we've said before, if her character were schizophrenic, she needs to be treated as if she's fragile. Yeah.
No, I'm not seeing that.
What's that?
I'm not seeing that.
Yeah.
Doesn't seem like she's functioning that way.
So again, you may be concerned about her, but be cautious about you initiating additional sessions. Let that go.
Yeah, she asked for it. I didn't offer.
So let her speak up for what she needs.
Right, exactly.
Good.
Exactly.
Good.
So, but in someone with an hysterical character, here's a better question. Are there some character types that are more prone to suicide?
Yeah.
Which ones?
Well,
there's somebody who's more impulsive, like a manic depressive.
Yeah. I mean, clearly, manic depressive characters much more prone to suicide than others, and the reason for that is one, the impulsivity you described, but also the instability and the fact that they can go into a terribly deep depression and see nothing other than the hopelessness. But also manic depressives are at risk for suicide when they start getting expansive. It's the intolerance of excitation is what the bottom line is. People will commit suicide to get out of any intolerable feeling, whether that's depression, pain, sadness, anger. Shame, yes. I mean, how many, so-called upstanding citizens or big corporate executives suddenly are exposed and they kill themselves. That's shame.
Really? Huh.
It's not depression usually, it's intolerable shame.
What about hysterics and suicide? Or patients with hysterical character.
Good.
I'm corrected.
Good catch. typically they're not as a bit higher risk for actually committing suicide, but they may make suicide attempts, and that's partly
it's the drama.
The drama, yeah, just creating excitation.
All right.
Because also they often, they can be terribly depressed, but they will come out of it much more quickly than someone with a basic depressive aspect to the character.
Yeah, I'm not seeing that with her. She's depressed about something, but it's not the whole way that she functions.
Right.
She goes to work, she's social, she has friends. But
well, did we say she has a subtype of oral repressed
hysteria?
That's what I thought. Yeah.
Right.
So
that's
with them, the tendency is to have a low grade depressive aspect to their character. They don't go into severe depressions the way someone with a phallic character or a manic depressive character might. The people with an hysterical character that I've seen go into a severe depression are ones that have a oral unstable block. That's almost...
What would that look like clinically?
What's that?
What does that look like clinically?
Well, they can have expansive periods. It's very much, it's if you imagine a manic depressive as phallic character with an oral unstable block. Mm-hmm. So it would be hysteria with an oral unstable block. Mm-hmm. So, they may at times be over talkative and expansive, but then they can be terribly hard on themselves and contract severely. And get stuck in that depression more than any other hysterical type character. It's not a common type, but I've seen it, and where that type I think is truly at risk for suicide among the hysterical characters.
Okay. Yeah, I'm pretty sure she's oral.
What's that?
I'm pretty sure it's oral repression. I don't think there's oral instability,
right,
from what I can see.
Remind me, what's her body type like?
So she's like 5'7", medium-sized breasts, kind of pear-shaped body.
Smaller on top than the bottom?
Yeah.
Okay.
Yeah. And
her lips, her mouth?
Well, she always purses her lips, like she bites down, thin-lipped.
Thin lips, yeah. Okay.
Yeah.
So
and her jaw's tight.
Okay, so that goes with the oral repression.
Yeah.
Okay.
Yeah. And you just see the tension.
But that body type is classical for that subtype.
Okay. Okay. Well, I'll see her Tuesday, and then I'll see.
Mm-hmm. No, but again, I think you're doing very good work with her. But someone like that gets stuck, it's hard because you'll feel it.
It's hard watching it.
But also don't forget, if you let yourself just make contact, you're going to feel what she's feeling, and that's our job, is to be able to tolerate feeling it, but not get stuck in them. As somebody said, learn how to walk in somebody's shoes, but you got to learn how to get out of their shoes.
Yeah, but the family doctor part of me wants to do something and go into fix-it mode. Yeah. And I today I just sat back and just let it happen, and that was harder on me. But I think she got in touch with more of the depth of what she's suffering with. She let me see how much she's struggling.
Good.
Which I acknowledge was progress for her.
Yeah, so she's not hiding as much, which is, as I've said to you many times, the cure for shame is coming out of hiding.
Yeah.
Yeah, and so she's doing that bit by bit, by you being present and not judging her. She's so afraid of being judged.
But the shame is so much.
Yeah.
It's...
What's her ethnic background?
Italian.
Italian, okay.
Why? What is that?
Well, usually Italians are more prone to guilt than shame. But
Shame's what, the Irish?
Yeah, shame is more with Irish. Yeah.
That's funny. Okay, so I wanted to switch gears and talk about a second patient, a 15-year-old with paranoid schizophrenic character type.
Okay.
So as her antipsychotic is being lowered, I'm seeing this more bubbly, fun, more engaged teenager come forward. And there's a superficial quality to her that's, hi, Dr. Marcel, how are you? You know, chipper and like very much on the surface. But every once in a while she'll shoot me a look that looks very serious. But she keeps it up top. You know, let's just talk. So, how are you? What do you do? What's going on? So in our last session, I found myself saying to her more things about myself as maybe like a lead to let her talk about herself.
Yeah.
So one of the challenges, she had a psychotic episode in the fall, and now she's not. You know, how do you recover from that? How do you kind of go back to your life as a teenager? And, you know, what's it like to know you function differently maybe than someone else? And that was the theme of the last session.
Okay, good.
Yes, it's very good. And so I shared with her how I sometimes flip letters and numbers around with dyslexia, and it really got in my way when I was studying in high school and college, and she's really amazed. How'd you do that? How'd you get through school? You know, she was very curious about me, and I said, you know, I guess it's what you do with it. You know, you make it work for you. You find your way around it. You know, you learn to live with it. You learn what works, what doesn't. And then I tossed the ball back to her and said, kind of like what you're doing, you know.
Good.
And the way you think differently, you think more creatively, you know, you have other interests, you like to write, you're more serious. And that rang true. So it was like I was using something about myself to help her open up a little bit more about what she went through, but she does not want to talk in depth about what happened when she was hospitalized.
I think that's wise.
She needs that wall up
to
be able to function.
Right.
But what I like what I'm seeing. There's this happy child or teenager coming back to life in a way. And her family's seeing it. I'm seeing it. She has two sets of friends, old friends from her old school. She's in a different school now. She has a bunch of new friends. She's going out. She's more social. So that just, it's amazing to me watching her bloom.
Great. Yeah. So what is the new school? So is it a therapeutic?
It's a therapeutic school.
Okay.
She has 20 students in her class.
Okay, but she's made new friends there.
She's made new friends.
That's since I last talked with me about her. That's great.
Yeah, well, some of these new friends have problems themselves.
Right.
You know, they're in the school for various reasons. And I think she's learning that, okay, so you're different, but that's okay. You can still function. You can still go to school, have your classes, learn, you know, and rebuild your life. And she told me she wants to maybe be a doctor one day. I'm like, yes. So,
I just want to make a comment about, you know, what you're saying, revealing things about yourself, because so much of our classical psychiatry training or the psychoanalytic training is you don't reveal. You know, you stay a blank slate, and
that's kind of how I was trained.
I know. I think any of us who were trained in the days when psychoanalysts still were part of the psychiatric training got that view. But if you look at it functionally, the question is, what is the function of you revealing something about yourself? And it's what. One of the stories I wrote in my book was the surgeon and the psychiatrist. So this is what I call the emotional sponge count. So as a psychiatrist,
What?
Yes, as a
What a great
psychiatrist, you've got to keep track of every instrument you put into the field, every sponge you put into the field. Otherwise, you can get in trouble by that, it getting buried and you not being aware that you've introduced this. But it's right for you to introduce things, but you got to keep track. You got to know what you put in the field, what the effect is. Watch the effect of you doing that. And with her, I don't have any doubt that her character is paranoid. So for you to reveal yourself, trust and truth are from the same word root. So she will trust you if she hears the truth. If she senses you're holding something back, and you have to hold things back, but if you can reveal something, I have a patient with that character type that I've revealed more to him about me than any other patient I've ever revealed, because
it's necessary.
It's the currency of, he now can say, well, I'm not going to tell you anything till you tell me something about you first.
Oh, isn't that interesting?
So
that's kind of what it feels like with her.
Yeah, she needs to have you show who you are before she can trust coming out to show who she is.
Yeah, and her experience with the other doctors that have taken care of her over the past 7 months, some of it was pretty awful.
Yeah.
Very mechanical, very cold, dismissive, rigid.
Yeah.
And she was just a scared young teen who had a real problem.
Yeah.
She could not integrate what was happening to her. So I think she may have looked at me that way, and that's starting to change. So,
but again, remember the emotional sponge count. Keep track of, with the patient I'm talking about, many times I've said, you forgot to read me my therapist Miranda rights. Anything I say can and will be used against me. Because often people with that character type, they will remember the slightest little detail. So be aware. It may come, with this guy, sometimes 5 years later, I heard something that I had said that I'd totally forgotten I'd said to him, and he brought it back up.
But that really flies in the face of traditional psychiatric training, where the doctor is
I think
more reserved.
But the function of that is if the doctor can't make the distinction between their own neurotic impulses and expressions compared to their own healthy ones, they're going to be spilling stuff, violating boundaries without being clear what the function of what they're saying is. So the solution to that has been a rigid rule: don't reveal anything. But what I'm saying is, if you approach it functionally, you can reveal a lot, as long as you see the effect of what you're doing.
Right. It had a great effect, I think.
Yeah, but it's also not just the immediate effect. You got to watch and keep track. Okay, yeah, I did tell her about that. Now what's happened with that, and you need to know the effect the next session, the month from now, so forth. Yeah.
Okay, so question about someone like this patient and that character diagnosis. As far as suicide goes, it's not on my radar now with her, but I do periodically think about that for all my patients. And I don't know what I want to ask, but just what would be a thing to look for, to wonder, maybe that's more likely. That somebody, like a teenager with paranoid schizophrenic character, would maybe do something to hurt themselves. And I'm answering my own question as I'm thinking this through.
Okay, good.
When the trust is broken. If I do something that changes the trust currency, to use your word, with the sponge count, that if I do something that is harmful in that way, that if the trust gets broken, then in their anger, they could take it out on themselves, I guess.
Yeah, but it's even more than that. What I was saying is any intolerable feeling. So one of the key things with someone with a schizophrenic character is that sense that they are disconnected from the rest of humanity. So if they feel totally isolated, removed, that can be intolerable. So that's where the trust comes in. If they can trust you, they have, in movie night, the movie Gravity that you love so much, that sense of just being adrift. If someone experiences that and it's intolerable, it can make them feel hopeless. So the trust with the therapist is that lifeline.
One of my old mentors back in my residency used to say often, you just sitting in the chair and being present is often enough.
Yeah.
Just you're being there.
Yeah.
You're listening. He said, maybe that's 80%. The other 20% is what you say, what comes out of your mouth and what you do.
Yeah.
Just being in the room with the person and being present, not just in the room, but really listening.
Yeah, but our term for that is contact.
Contact, exactly.
So,
Yeah, and I feel like that's been improving with this teenager. But I feel like there's so much more to her. Again, those serious looks that she shoots at me once in a while. She'll, she'll play with some of the toys in my office, and she's having fun with it, and she'll look up at me, and there's this serious look. It almost the response in me, like when I see it, is, whoa, there it is again. What is that? There it is again. Like there's this other human being way below the surface, and I don't go running after it. I just see that it's there, and when it comes up, it comes up. But my guess is she thinks about things on such a deep level that maybe she cognitively or emotionally just can't really allow herself to experience because it's too overwhelming.
We always talk about the schizophrenic character has a problem with integration, so that's exactly what you're talking about. She may have tremendous talents and health, but that's not integrated in how she can live day to day well enough. I mean, that's your work, is to help her be able to integrate this. And I don't remember if we've talked much about it, but I'm always looking at what is the healthy aspect of someone that underlies the neurotic character. And if schizophrenia is basically a disorder of the integration between perception and excitation, then what is the basic talent, the natural ability this person has? And I think part of it is the capacity to manipulate perceptions.
What does that mean?
To be able to see things, not manipulate's not the right word, but to be able to see things from very unusual points of view. And I think when that goes off, they can hallucinate, have a distorted perception of that sort, or delusions that are distorted perceptions. But I think that's the basis of why people talk about art and madness going hand in hand. An artist has the capacity to see things in a way nobody else has seen. And I think someone with the nature that underlies schizophrenia has that capacity to perceive things in very different ways, and if they don't match social norms, they start to feel crazy. So I think that's what you're picking up underneath. You showed me the drawings she did.
Yeah.
I mean, she is able to capture just in quick, informal drawing a way of looking at things that are very different.
Yeah.
So, I think Reich said it a number of places, is the great artists, see more than they can tolerate, and that's what can make them go crazy. Yeah.
Huh. And I think her connection with some of her new school friends who see the world differently.
Okay, yep.
That's been good for her.
Yeah, okay.
She's not alone.
She's not alone. And
she's got other teens who are, okay, they have their way of seeing things too, and that's okay.
Right.
The teachers, the counselors, they get it. Whereas at a traditional high school, they didn't get it.
Yeah.
For whatever reason. And in this school, she's got more emotional connections. So.
Yeah, good.
Yeah, and she really likes school. She's doing well.
Oh, good. No, that's all since the last time you talked to me about it. That's great.
Doing well. Getting A's and B's and everything, and and she's writing. I've encouraged her to write. She likes to write.
Good.
And
just one more thing. Yeah. Don't forget what you said. Just being there and being present, so that contact occurs between the two of you, is absolutely what her therapy is about.
How do you feel after listening to these discussions? What do you think? When you picture two psychiatrists discussing a patient's care, is this what you imagined? We are interested in your questions and comments. Connect with us using the links in the show notes. If you like our work, be sure to subscribe and leave a favorable rating. Here's where I normally tease the next episode, but it's harder to stick to a plan during the pandemic, I found. Have you noticed this? We'll have an episode every month, pandemic or not, but for now, I'll leave you in suspense. Since 1968, the psychiatrists affiliated with the American College of Orgonomy have been helping patients discover greater satisfaction, health, and overall well-being in their lives, whether patients suffer with mental illness, struggle with addiction, or feel unsatisfied with their work lives or relationships. Medical orgone therapy, as practiced by the physicians at the ACO, offers a way forward, often without the use of medication. I'm Dr. Chris Burrett. Thank you for listening to In Contact with the ACO. Connect with us using the links in the show notes.